Recording in progress.
That's very loud. All right, can everybody see the screen? We got the chapter up and everything. Great. So, for some reason, I was thinking I've been scatterbrained for the past, like I said. All right, so today we'll be going over chapter 21, which is going to be endocrine and hematologic emergencies. And then 22, it'll be chapter 21 and 22. Because on the module test, we'll be covering chapter 16, 17, 18, 19, 21, 22, 23, and 24. It's roughly 7 or 8 questions from each chapter. From that, I think it makes up 56 questions. And 56 questions in 60 minutes. So I gave a little bit of leeway time there. Most of your questions for the module test, I'll go ahead and tell you, are going to be scenario based. So it's going to be that repetition, that making sure that you're following the process, those assessments, making sure you're following those assessments. Okay, making sure you're asking the right questions, things like that. So it's going to be very important. That's why I say I'm going to try and lean more of these major tests. I'm going to try and lean more towards what you may see on the AEMT test, which is a lot of scenarios, or the NREMT test, which is possibly a lot of scenario-based questions. I want you to feel that repetition and that time frame. So we'll be working on that. Sets and reps. All right, so chapter 21, endocrine and hematologic emergencies, is what we'll be doing, and then we'll be doing chapter 22 right after this. So stay tuned. All right, National EMS and Education Standards and Competencies. All right, introduction. So the human endocrine system directly or indirectly influences every cell, organ, and body function, as you can see there. So the endocrine disorders can have many signs and symptoms. It requires a thorough assessment and immediate treatment as soon as you can get to it. It's also you see here under hematologic emergencies, what it's got there, you can offer support. You can offer a lot of support in these emergencies. You can possibly save a patient's life. But they are difficult to assess and treat. So the endocrine system is comprised of a network of glands and produce and secrete chemical messengers called hormones. There's some of the glands that will have some of those hormones. All right, so what are hormones, you ask? Hormones are going to be chemical substances. It's produced by the glands that have special regulatory effects on other organs and tissues. Endocrine glands, they secrete or release chemicals such as hormones inside the body. And then the main function of the endocrine system itself and its hormone messengers is to maintain homeostasis and promote permanent structural changes. All right, pituitary glands. Pituitary glands are going to be located at the base of the brain. The pituitary gland is divided into anterior and posterior regions. 6 of the hormones secreted by the pituitary gland stimulate other endocrine glands and are referred to as tropic hormones. You can see there a few of the hormones that are secreted. So the ACTH targets the adrenal cortex and causes it to secrete cortisol. All right, the thyroid gland or the thyroid hormones are secreted in response to stimulation of the thyroid gland by the anterior pituitary gland. So it's going to secrete thyroxine when the body's metabolic rate increases. So and this is going to stimulate energy production in cells when that metabolic rate increases. So the thyroid gland also secretes calcitonin, which is going to help maintain the normal calcium levels in the blood. Also, calcitonin travels to the bones where it stimulates the bone building cells to absorb the excess calcium. All right, the pancreas. So the endocrine component secretes hormones from cell groups called the islets of Langerhans, right? These cell groups within the pancreas act like an organ within an organ, secreting the polypeptide hormones, insulin, and somatostatin. So glucose is one of the basic sugars in the body, along with oxygen. It's the primary fuel for cellular metabolism, and it's a major source of energy for the body itself. Without glucose, or with an extremely low glucose level, brain cells rapidly suffer from permanent damage. Um, with the exception of the brain, insulin is needed to allow glucose to enter individual body cells to fuel their functioning. Excuse me. So the regulation of glucose levels in the body it's a complex and dynamic process, as you can see. Insulin is responsible for the removal of glucose from the blood for storage as glycogen, fats, and protein. Sorry, and protein. So the islets of Langerhans secrete insulin, which is carried by the bloodstream to the cells. As you can see here, it says the insulin increases cell membrane permeability and mediates the transport of glucose across the cell membrane into the cells. The cells use glucose to produce energy through a process that includes glycolysis. So the alpha cell of the islets of Langerhans release the hormone glucagon. When glucagon enters the bloodstream, it raises the blood glucose level and brings the body's energy back to normal by stimulating the liver to convert stored glycogen back into glucose through a process called glycogenesis. Glycogen. Uh, oh, well, Glycogenolysis. So the glucose is secreted into the bloodstream where cells can use it for energy. If stored glycogen levels are depleted, the cells begin to metabolize fats, proteins, and other non-carbonate um, sources, thus producing new glucose, which is a process called uh, gluconeogenesis. Gluconeogenesis. So the pathophys of the endocrine system. So as you see here, endocrine disorders can be caused by either hypersecretion or inefficient secretion of a gland. Hypersecretion presents an overactivity of the target organ regulated by the gland. Insufficient secretion results in underactivity of the organ controlled by the gland. So hyperthyroidism and hypothyroidism are two serious illnesses of the endocrine system, right? Most of the endocrine emergencies you'll encounter will be related to diabetic emergencies, secondary to abnormal insulin secretion. So diabetes mellitus. Diabetes is a metabolic disorder now thought to be associated with a group of complex diseases with many causes. Diabetes mellitus, gestational diabetes, hypoglycemia, hyperglycemia, diabetic ketoacidosis, and hyperosmolar hyperglycemic syndrome, to name a few. So the end result of diabetes is, you see there, hyperglycemia. Medically, the term diabetes refers to a metabolic disorder in which the body's ability to metabolize simple carbohydrates, such as glucose, is impaired. So diabetes is characterized by the following systems you see here. So diabetes mellitus is characterized by the body's inability to sufficiently metabolize glucose. Mellitus is the reference to the presence of glucose in the urine. So glucose builds up in the blood, overflows into the urine, and flows out of the body. Diabetes mellitus is responsible for, you can see, a myriad of life-altering complications, some of which are listed right here. So in the kidneys, high levels of glucose in the blood cause the kidneys to work harder than normal and can result in decreased kidney function over time. In the heart, when diabetes is poorly controlled, the process of lipolysis raises the level of fat in the blood, increasing the risk of atherosclerosis and coronary artery disease. The microscopic deterioration of the vessel walls, called microangiopathy, results in swelling of basement membrane cells. As you can see there, cerebrovascular disease, stroke, and hypertension is something else it causes. The eyes, high glucose levels in the blood damage the vessels in the eye, causing swelling, wall weakness, and obstruction. You also have neuropathy. So neuropathy is nerve damage that results in loss of sensation and function in the area innervated with or innervated by the affected nerves. Neuropathy associated with diabetes, it often affects nerves, causing diminished sensation and function in the extremities themselves. As you can see here, they kind of die off. So, because of the widespread effect of diabetes on all systems of the body, any pre existing condition will be more difficult to manage. Any kind of distress can have a negative effect on the patient and can result in them calling 911. So two forms of diabetes mellitus exist. You have type 1, formerly known as juvenile onset diabetes. And you have type 2, which is formerly known as adult onset diabetes. Prediabetes is now recognized as a warning sign that may precede the development of type 2 diabetes. So historically, type 1 has been referred to as insulin dependent diabetes mellitus or juvenile onset diabetes because it generally affects children. The body develops autoantibodies that incorrectly identify the body's own tissues. The rate of beta cell destruction is variable amongst it. Latent autoimmune diabetes in adults is a variant type 1 of type 1 diabetes that occurs in adults older than 30 years. So patients with latent autoimmune diabetes in adults will ultimately require insulin therapy. So increased activity and alcohol consumption can result in low blood glucose levels. It always requires the use of insulin that's administered by injection or through an insulin pump. So the insulin pumps, they're going to provide improved control of blood glucose levels and a better quality of life for many patients. There's a pump there. All right, so type 2 diabetes mellitus. It's the most common form of diabetes. Now, the blood glucose levels are elevated because the body becomes resistant to the insulin produced. Type 2 diabetes, it typically develops when a person is middle-aged. although the disease is becoming more common in younger people as well. When glucagon levels remain high, excess amounts of glucose are produced, and that's going to result in high blood glucose levels. So some of the symptoms are listed here. So Metformin, the medication most commonly prescribed for management of type 2 diabetes, it causes a decrease in glucose production. All right, pre-diabetes. All right, so from this, the goal for a diabetic patient is an A1C level of 7% or less. You want your A1C levels to be 7% or less. So there are some risk factors for prediabetes. So also being of African American, Hispanic, Latino, American Indian, Pacific Islander, and some Asian American racial or ethnic backgrounds can put you at higher risk as well. Gestational diabetes, or having given birth to a baby who weighed more than 9 pounds, and then being physically active fewer than 3 times per week can also put you at risk. So losing 5 to 7% of a patient's body weight and getting at least 150 minutes of physical activity per week, it can prevent or delay the onset of type 2 diabetes. All right, gestational diabetes. It's a form of glucose intolerance that can occur during pregnancy. Most common gestational diabetes will resolve before delivery. Blood glucose crosses the placental barrier also. When a pregnant woman is hyperglycemic, high levels of glucose enter the fetus, causing increased production of insulin by the fetus. It is thought that two hormones produced by the placenta, progesterone and estrogen, can result in insulin resistance. It does not produce any type of birth defects. Some management of it is going to include diet modification, exercise, and blood glucose testing on a regular basis. All right, hypoglycemia. In a person with type 1 diabetes, it's often the result of having taken too much insulin or too little food or both. So a hypoglycemic crisis is also known as insulin shock and is the result of hypoglycemia. So stimulation of the autonomic nervous system, it generates signals that are going to allow production of the counter-regulatory hormones to increase. The liver uses these products to make new glucose for the body in a process called gluconeogenesis. So some of the most common signs and symptoms of hypoglycemia are going to include blood glucose level less than 70. So blood glucose levels, or CBGs, whatever you want to call them, less than 70. Hunger, agitation or combative behavior that can't be explained, altered mentation or confusion, nausea, weakness, dizziness, or fainting, tachycardia, which could indicate poor cardiac output, cool, clammy skin. So, hypoglycemia is the most common problem experienced by patients with either type 1 or type 2 diabetes. A hypoglycemic patient appears intoxicated because of slurred speech and lack of coordination, and may be paranoid, hostile, or aggressive. So hypoglycemia, it can be treated very easily. Severe hypoglycemia, however, resulting in the loss of consciousness or altered mental status, is more common of a reason for a call to 911. So as an EMS professional, you will need to promptly provide treatment for those patients. Do not discount the possibility of hypoglycemia in a comatose patient either, just because the patient's not known to have diabetes. So don't let a known diagnosis of diabetes prevent you from considering other causes of coma either. So hyperglycemia and diabetic ketoacidosis. Hyperglycemia, it occurs when blood glucose levels remain elevated and mechanisms that normally correct this elevation fails. Can be caused by excessive food intake, insufficient insulin dosages, infection, illness, injury, surgery, and also emotional distress can cause it, or emotional stress can cause this. So repeated episodes of hyperglycemia will cause several physiologic changes that have detrimental long-term effects. When serum glucose levels rise above tolerable levels, physiologic changes occur representing pathologic conditions, and this is called diabetic ketoacidosis, or DKA, and hyperosmolar hyperglycemic syndrome, also, or otherwise known as HHS. And there's your little chart there. When fat is used as an immediate energy source, Chemicals called ketones and fatty acids are formed as waste products and are difficult for the body to excrete. Okay, so large quantities of ketone bodies in the bloodstream cause a decrease in the blood's pH and result in metabolic acidosis. The ketones are responsible for the sweet, fruity breath or odor associated with DKA. If the patient isn't given proper fluid rehydration and insulin to reverse fat metabolism and restore the use of glucose as a source of energy, ketoacidosis will progress to unresponsive diabetic coma, and eventually it could be death. So patients in DKA are seldom deeply comatose, though. So signs and symptoms of hypoglycemia versus hyperglycemia. A comparison of hypoglycemia and hyperglycemia. There's a table in your book, table 21-2, that shows you that. So the signs and symptoms of simple hyperglycemia are usually mild. They're going to include blurred vision, polyuria, polydipsia, polyphagia, orthostatic syncope, frequent infections, and skin ulcerations. The resulting signs and symptoms manifest these etiologic factors: polyuria, polydipsia, polyphagia, nausea, vomiting, tachycardia, Kussmaul respirations, warm, dry skin, and dry mucous membranes, fruity odor of ketones on the breath, abdominal pain, sometimes a fever. The respiratory rate is usually elevated, and the tidal volume is increased because of ketonemia. Acidosis and to relieve excess burden of CO2 by the body, it's going to do this as well. So these respiratory changes result in hypocapnia, and then DKA it's going to result in both Kussmaul respirations and metabolic acidosis. So in patients with type 2 diabetes, DKA is rare because insulin is still present. With increased duration of type 2 diabetes, a loss of pancreatic insulin production may still occur. So there's the comparison chart between hypoglycemia and hyperglycemia. So HHS is also called hyperosmolar non-ketotic coma, or HONK, HONK. What else we got here? So the clinical features of HHS or HONK and DKA tend to overlap and are often observed simultaneously. HHS or HONK often develops in patients with diabetes who have a secondary illness that results in reduced fluid intake. So patients with this HHS and HONC do not experience ketoacidosis. So patient assessment. So you're going to form that general impression of that patient and perform your rapid scan. How does the patient look? Are they anxious, restless, or listless? Are they apathetic or irritable? Are they interacting appropriately with the environment around them? In patients with altered mental status, you should go ahead and suspect low glucose level. Of course, if you can't see anything obvious, right? You're going to identify those life threats and make any life-saving interventions if you need to. If they're unresponsive, the patient may have an undiagnosed diabetes. You can perform the cervical spine. Okay. You can perform a cervical spine immobilization when indicated and provide rapid transport. You can assess the patient's airway and breathing. Patients showing signs of inadequate breathing and altered mental status or oxygen saturation of 94% or less should receive high flow oxygen, 12 to 15 liters a minute, via a non rebreathing mask. A patient who's hyperglycemic may have rapid deep respirations or Kussmaul respirations and a sweet, fruity breath odor. So a patient who is hypoglycemic will have a normal or shallow to rapid respirations. If the patient is not breathing or is having a difficulty time breathing, sorry. If the patient is unresponsive, if the patient's not breathing or having a difficult time breathing, you're going to open the airway and insert an airway adjunct, and then you're going to assist those ventilations if needed. You're going to want to continue to monitor the airway as you provide care for that patient. If the patient's unresponsive, you're going to treat him or her as any other unresponsive patient with attention to your airway. And then next, if dextrose is indicated, you're going to use the use of an advanced airway should be avoided until dextrose has been administered. Because if you administer it shortly after they come out of it, you may have to react pretty quickly. So carefully monitor the airway of the patients with hypoglycemia and hyperglycemia crisis or other complications such as stroke or seizure. So here's some differences. A patient with dry, warm skin is an indicator of hyperglycemia, and a patient with moist, pale skin indicates hypoglycemia. So in your history taking, you're going to investigate the chief complaint, and then responsive patients usually are able to provide their own medical history. If the patient has eaten but has not taken insulin, hyperglycemia is more likely. If the patient's taken insulin but not eaten, hypoglycemia is more likely. If the patient's not thinking or speaking clearly or is unresponsive, You're going to attempt to obtain medical history from a family member or bystanders. So you're going to want to obtain that sample history, and you're going to ask the following questions of any ill patient who has a history of diabetes. You're going to ask, do you take insulin or pills to lower your blood glucose? Have you taken your usual dose of insulin today? Have you eaten normally today? Have you had any illness, unusual amount of activity, or stress today? And then also, you're going to ask the patient or the family about some of the following stuff. You'll ask them the patient's last meal and the last insulin dose they had, any vision changes, headaches, dizziness, or bleeding, a recent change in patient's bowel movements or eating habits, tingling or numbness or swelling in the extremities. And then also, when you're assessing your patient, you want to make sure that he or she doesn't have any type of emergency medical identification device either. Be on the lookout for them. I had a friend of mine actually had a tattoo on his wrist. So you're going to assess unresponsive patients with a full body exam and look for clues to their condition. So you want to, for an unresponsive patient, you want to look for problems or injuries that are not obvious. The patient may have sustained trauma that results in dizziness or from changes in level of consciousness at that. So an altered mental status can be caused by something else, as you all know. If you're using the systematic examination, that's going to help. So, of course, you're going to obtain that Glasgow Coma Scale, and you're going to score the patient's neurologic status. You're going to check vital signs. And then as far as monitoring devices, glucometers are going to be your friend, right? But it's also important to read and understand the operator's manual. So a normal, or meaning by this, you'll get these error codes, and you need to know your specific brand or model's error codes, what it means. Because usually your glucometers that you carry in your bag only go as high as 600. So they only go as high as 600. So it'll read some error code that tells you that it's high, or it can read an error code that tells you that it's very low also. So the range that you're going to be looking for in non-fasting adults and children is going to be between 70 and 120. And then the blood glucose level in neonates should be higher than 70. So it's going to be important to assess a patient, or it's going to be important to reassess the diabetic patient frequently to assess any type of changes. Even if you've given especially if you've given a treatment, you want to make sure you do that. So you want to monitor their airway carefully to, potential vomiting or anything like that. So patients who are hypoglycemic when they're given large quantities of glucose orally, they tend to become very nauseated. You want to document each assessment and your findings of each assessment, the time of your interventions, and any changes in your patient's condition. So you want to base your administration of glucose on serial readings. And then also keep your hospital personnel informed if need be. But what it's talking about there is based on your serial readings, is like we talked about the other day. Don't just pound them with the full with the full container of D50. Titrate for effect, right? Titrate for effect. So your general management of this patient is you're gonna place that patient in a position of comfort. If the patient has AMS, you're gonna establish an IV line with a normal saline or a saline lock. You're going to measure the CBG level immediately and initiate and treat if the reading is less than 60. Glucagon is administered 1 milligram intramuscularly or IM with a greatly increased recovery time if it works. The decreased osmolarity in these concentrations is less caustic to the veins and tissues. If the patient's condition doesn't improve after a dose of dextrose, and if you suspect a narcotic overdose, you may want to then consider your Narcan. You're going to transport the unresponsive patient supine or transport them in the lateral recumbent recovery positions. If there's any indications of increased intracranial pressure, you're going to transport with the head elevated at least 30 degrees to 45 degrees and keep the head midline. Always keep the mouth and pharynx suction free of secretions, vomitus, and blood. So your management of hypoglycemia, it's going to includes immediately increasing. You're going to have to increase that blood glucose level. So that in a hypoglycemic patient, when you give this glucose or any type of glucose you see here, the gel, you want to make sure that they are alert and that they're able to swallow without risk of aspiration. So do not give sugar-free drinks that are sweetened with saccharin or other synthetic sweetening compounds. It's not going to work. So first line medical treatment for patients with hypoglycemia is going to be to administer that oral glucose. If not possible, then you move on to administer dextrose via IV route. So the only contraindication of the glucose, the oral glucose, is going to be the inability to swallow or unresponsiveness. It's going to be that. If you screw that up, then they aspirate. They aspirate this stuff, and then you're in bigger trouble. You're going to be working harder. So you're never going to give anything by mouth to an unresponsive patient. Even if you do suspect hypoglycemia. If they're unresponsive, you're going to use an IV or IO glucose or IM glucagon. So in any of these patients, if they're presenting with signs of dehydration, you're going to administer 20 mils per kg bolus of isotonic crystalloid solution, and then reassess after the initial bolus, and repeat if it is necessary. So if you do wind up having to do dextrose IV via IV intravenous, you're going to administer the IV dextrose if the hypoglycemic patient has an altered mental status or unable to swallow, right? Some contraindications of this IV route or of this dextrose are going to be increased intracranial pressure or possible intracranial bleeding. You don't want to give it at that point. So that's why we say look for those possibilities of ICP or increased ICP. Administering glucose in the presence of hypokalemia is going to worsen the effect of low potassium. So make sure you rule out that hypokalemia as well. So the dose of dextrose are going to be as follows. You got 12.5 to 25 grams of D50 in adults. 12.5 to 25 grams. And you got 0.5 to 1 kg per, or 1 gram per kg per kilogram dose via slow IV push of D25 for children aged 1 year and older. All right. Then you got 200 to 500 milligrams per kg of D10 solution, slow IV push for neonates and infants. You're going to give dextrose by IV push while carefully monitoring for infiltration into the local tissue. That's a no good if that happens. So the steps for administering that dextrose to a patient with altered level of consciousness are going to be, you're going to insert an IV line with the largest catheter in the largest vein. Okay? You're going to attach an IV bag of isotonic crystalloid solution, such as normal saline. You'll check the IV line carefully to confirm that it's patent and flowing freely. And then you're going to inject a test bolus of 10 to 20 milliliters of normal saline. So what is that? 10 to 20. So 10 milliliters is what? How do we usually give that? Through that syringe, right? The pre-filled normal saline syringes. What do we call those? Flush. That's right. So we'll give them that flush, just to make sure that the line's patent, open, ready to go. And then we're gonna open the IV line wide open, and then we'll crimp the line superior to the administration port, and then we're gonna administer the 12.5 to 25 grams or 25 to 50 milliliters of dextrose slowly. You want to depress the plunger slowly so that you avoid rupturing the vein. You don't want to do that. When administering D50, draw back on the syringe to observe a blood return. You want to make sure that you see that. And then recheck after 1/2 of the dose has been given by pulling back on the plunger again to check for blood return. And then flush the IV line by opening the line for a few seconds. Open it up, flush it for a few seconds, and then let her rip. Easy peasy lemon squeezy. So administering glucagon. Glucagon IM is going to be an option when IV access cannot be obtained by a hypoglycemic patient, which happens quite a bit. Sometimes it can't. Sometimes they're hard to find veins on. Glucagon is only effective when there are stores of glycogen to draw from. They're usually supplied in, as you can see here, they're usually supplied in 1 milligram ampules. So the dosage for this is going to be 0.5 milligrams for children who weigh less than 20 kgs or 20 kilograms. We don't go by pounds. Once you hit the medical field, you know this. We don't use pounds. We use kgs. And we turn everything into kgs, okay, or kilograms. All right? Dosage is the same as adults for children who weigh more than. Dosage is the same for adults for children who weigh more than 20 kgs. So anything more than 20 kgs is going to be the same dosage in adults. Glucagon should be used in conjunction with dextrose whenever it's possible to do so. So, management of a hyperglycemic patient and DKA. If the patient's glucose level is more than 250, then the physician will probably order treatment for DKA, okay? So the goals of pre-hospital treatment of DKA are to begin rehydration to correct the patient's electrolyte and acid-base abnormalities. First off, you're going to maintain that airway and administer oxygen. Be on the lookout for any type of vomiting. Have your suction ready. And then consider paramedic backup for definitive airway control if it's needed. What you're going to do is you're going to gain IV access and administer 20 milliliters per kg bolus of isotonic crystalloid solution, which an example of that would be normal saline. The treatment of a patient that is symptomatically, treat the patient symptomatically, okay? Provide oxygen and IV fluid as needed. So as you can see here, you're just trying to restore fluid to this patient. And they may offload it as soon as you give it, sometimes, your DKA patients. So management of HHS or HONC, we talked about earlier. So management is going to follow the pathway for dehydration and altered mental status. Advanced airway management may be indicated, and it should be completed as early as possible when you get there. C-spine immobilization should be considered for an unresponsive patient if there wasn't anything witnessed. All right. So you want to obtain a blood glucose level as soon as possible. And then you want to get a large bore IV access. 18 gauge is good. And that should be gained as soon as possible. In patients with a history of heart failure or renal insufficiency, you're going to give that fluid sparingly. So fluid deficits in patients with HHS or HONC may amount to 10 liters or more. All right, so hematologic emergencies. Hematology is the study of blood. It also addresses the ways in which the constituent parts of the blood are involved in health and disease. So some of the blood components they're going to include, we talked about them in earlier chapters. They're going to include your RBCs or red blood cells, your WBCs or white blood cells, platelets, individual proteins involved in bleeding and clotting cascades, and then also some of your hematologic disorder refers to any disorder of the blood, okay? Hemolytic disorders refer to diseases process that cause the breakdown of red blood cells. Hemostatic disorders refer to bleeding and clotting abnormalities. So as an AMT, you got to have an understanding of your hematopoietic system and the hematologic disorders and know how to respond to each of them. So blood and plasma. Without blood, we wouldn't be able to live, right? So some functions of the blood: respiratory, it's going to transport oxygen from the lungs to the tissues and carbon dioxide from the tissues to the lungs. Nutritional, it carries nutrients from the digestive tract to cells throughout the body. Excretory, it ferries waste products of metabolism from the cells where they're produced to excretory organs. Regulatory, it's going to transport hormones to their target organs and transmits excess internal heat to the surface of the body to be displaced or dissipated. Uh, Defensive, it carries defensive cells and antibodies which protect the body against foreign organisms. That's what your blood does. All right, tell you what, we're close enough. Let's take a 10-minute break and then we'll get back at it. Pull up my handy do dandy thing here. Oh Lord, that's loud. Love the energy today. Climb in the leaderboard. No. No Peloton. All right. All right. 10 minutes. I'll see y'all in a little bit.
unmute the mic.
Be yelling. All you got to do is read my lips. All right, so plasma, it's a straw-colored fluid. It's 92% water, 6% to 7% of proteins are in that. It's a plasma. It accounts for about 55% of the total blood volume. And you see there the rest of it. Platelets responsible for clot formation. So here's some examples of blood forming organs. So some of the major players are going to be your bone marrow. It's the primary site for blood cell production. It's found in most long bones, pelvis, skull, and vertebra. In the liver, it produces clotting factors found in blood. It filters blood, removing toxins. It's essential to metabolism and homeostasis. It's highly vascular and stores blood in itself. The spleen is also very vascular. It filters and breaks down RBCs and then helps produce WBCs. And it's important for providing also homeostasis and infection control. Your spleen is good for infection control. So your blood classifications, like you can read right there. So types O, A, B, and AB. So some blood reactions are similar to anaphylactic reaction. It can cause severe circulatory collapse. It can even kill you. So most of the time, you can ask, but the hospital is going to check of what is the blood type. Unless you're one of those services that can give blood, like in helicopters, stuff like that. So, but a lot of times they can give blood. Then you give, a lot of times they'll give type O blood. So, type O is universal. Usually an interaction or usually a reaction, you'll see it within 30 to 60 minutes after the transfusion. We've been over sickle cell disease. There's your red blood cells, normal red blood cells versus sickle cells. So, people with sickle cell may experience frequent infections, which can lead to sepsis and death if not taken care of. So, over time, various organs can be destroyed as the circulation is impeded. And then patients may have signs of mild dehydration, splenomegaly, cardiomegaly, and also many other types of complications. There's some potential complications from sickle cell disease. So anemia is defined as hemoglobin and RBC levels that's lower than normal. So anemia can also be caused by hematologic disorders resulting from a deficiency of an enzyme known as glucose 6 phosphate dehydrogenase or dehydrogenase. Sorry, it's one of those mouthfuls. The most common type of acquired anemia develops from the flow of RBCs when the flow of RBCs is disrupted, owing to problems with blood vessel linings or blood clots themselves. In autoimmune disorders, RBCs are destroyed by the body's own antibodies. Anemia can also have serious consequences for people who travel to high altitude areas. Patients with anemia will report feeling worn down or having no energy or feeling as if they've exerted themselves. Okay. So, some clotting disorders. Clotting disorders are abnormalities in clotting of the blood. You can see thrombophilia there. It affects a large number of people around the world, actually. uh, Pulmonary emboli, secondary to deep vein thrombosis, are leading causes of death in hospitalized patients. So many patients with thrombophilia receive anticoagulant medications that thin the blood. So here's some risk factors. All right, there's hemophilia. So hemophilia A is or hemophilia. It results in increased bleeding time. It occurs predominantly in males. So it's classified into two primary types: hemophilia A, which is the most common type, and low. It's got low levels of factor 8, and then hemophilia B. It's the second most common type, and deficiency of factor 9. The levels of factors 8 and 9 are going to determine the severity. So some signs and symptoms of hemophilia A and B are the same. You see there, acute chronic bleeding can occur at any time. Injuries or illness that cause bleeding in hemophilia patients should be taken very seriously. Um, Spontaneous intracranial bleeding is common, and it's a frequent cause of death as well. So, in addition to managing your ABCs, you got to be alert for acute blood loss. Uh, Note any bleeding of unknown origin also. So, patients may exhibit some signs of hypoxia um, owing to the reduction of oxygen carrying capacity of blood. That's why. So, disseminated intravascular coagulation. So, the mortality rate for patients with DIC is it's quite high. All right, seat size up for these. So, as before, we talked about that inadequate breathing, altered mental status, SpO2 of 94 or less. Make sure that they're receiving that high flow oxygen. So, increased heart rate, compensatory mechanism. Should know that. So, rapid transport is going to depend on the severity of the patient's condition, um, as well as a patient's wishes. So, it is. What the mess? I didn't turn it off. That was funny. All right, back at it. So it's recommended to for that patient go to the ED if they're experiencing a sickle cell crisis or a history of hemophilia and bleeding. You may want to highly recommend it. So some physical signs such as swelling of the fingers, toes, priapism, and jaundice. It may lead you to believe whether the patient's experiencing a sickle cell crisis. So if the patient reports pain, try to isolate if it's a single location or whether it's felt throughout the entire body. So if they've had sickle cell disease, then you want to ask some questions in the sample history. And there they are, right there. So as you can see there, using the pulse ox, the O2 saturation reading, it may be inaccurate because of the patient's anemic state. So we want to make sure that we're aware of that. And as always, make sure that you reassess that patient, the condition, reassess any interventions, make sure your documentation is squared away. So, says here your emergency medical care would include. So, as far as oxygen, the amount needed and how it's given depends on the severity of the patient's condition and respiratory status. As far as fluids, you want to initiate IV fluid replacement as indicated for the specific disorder or chief complaint they have. For transport, you want to transport to the closest, most appropriate facility. For pharmacology, pain management is going to be necessary. Remember that the patients have lived with the disease for a long time. Thus, they may have a high pain threshold for it. But you want to follow your local protocols for pain management as far as that goes. Comfort and rest, you're gonna place the patient in a position of comfort, and then cover the patient and maintain the body temperature, right? And then psychological support, you got to be supportive, communicate with the patient what you're doing, what's going on, why you're doing it, so on and so forth. So for specific conditions, you're going to perform a thorough assessment first, right? To help sort out any types of, help sort out signs and symptoms. You're going to care for the sickle cell disease. It includes, some of the things may include analgesics for pain, antibiotics to prevent infection, and blood transfusions are required. Maybe a paramedic. We do know that a higher echelon of care is needed, so get them to it. And anemia, you want to make sure that you monitor their airway and breathing. So don't be surprised if you have to control substantial nosebleeds in patients with anemia. If a patient is reporting chest pain, you want to call that for that paramedic backup as quickly as possible. So, in patients with hemophilia that may require IV therapy, and in some of these cases with unstable hypotension, you need to understand that the patient actually needs a transfusion or plasma is what they actually need. So it's critical. It's critical to identify that DIC and establish treatment as early as possible if you can. All right, that is the end of that one. Do we have any questions about any of that? Fantastic. So the test on chapter 21 will be open tonight. The quiz will be open tonight at 2200. All right, let me get this resized up. No questions on chapter 21 before we move on to chapter 22. All right, so the quizzes for Chapter 21 and 22 are going to open up tonight, as well as the module test for module 3 are going to open up tonight as well. For the test last week, I'm going to open those up for an extended amount of time as well, so people can finish it. And your module 3 discussion, which is the discussion about the COVID and the heart stuff, only 4 people have done it so far. So let's make sure that we get that done. It's going to be that's a 20% grade there. So let's make sure we get it done. So we got a lot. So this week, there's a lot to do. It's going to be a busy week for everybody across the board. And hopefully everything will be lined out next week. We'll be back on track, back in order, back on a regular, good schedule. Except of course, for the, what do you call it? For the boot camp. Boot camp will be, 1 week later on the 18th and 19th. We'll tackle it. I'll get some more details out there about it as soon as I find out from Rob Roy. All right. Let's get started with this. So, immunologic emergencies, chapter 22, what we'll be starting on now. So there's your National EMS Education Standard competencies right there. So at least 1,500 Americans die annually because of acute allergic reactions. You need to be aware of the possibility of acute airway obstruction and cardiovascular collapse and be prepared for that. Allergic reaction is an exaggerated immune response to any substance that may require epinephrine or, that may require epinephrine, okay? So, anaphylaxis is an extreme systematic form of allergic reaction involving 2 or more body systems. You got to be able to distinguish between the body's unusual response to an allergen and an allergic reaction. Okay, so like a hypersensitivity and then a allergic reaction. What's the difference? So the ability to recognize and manage the symptoms of an allergic reaction may be the only thing standing between you and a life and death possible situation. You'll get to use the EpiPen. The amazing EpiPen. So, anatomy review. We have been through this anatomy review. And I'm not going to sit here and pound you on the anatomy review. So the figure here, it shows the sequence of events in anaphylaxis. A is going to be the antigen is introduced into the body. B is going to be the antigen-antibody reaction occurs at the surface of the mast cell. C is going to be the mast cell chemical mediators release. Okay, D is going to be the specific body or the specific antibody reacts with its corresponding antigen. E is going to be the chemical mediators or exert their effects on the end organs. Notice how the very descriptive words ouch, zap, bang, boing, boom. That's very descriptive. All right, so vaccines produce immunity against disease. The body develops antibodies in response to the vaccine. It produces an immune response to neutralize the invading disease. This develops antibodies in a controlled way. If actual virus then enters the body afterward, the virus is identified and the antibodies are produced to kill it. Okay. A secondary response is going to be the intense response to an invading virus. So acquired immunity. The administration of a vaccine is going to the administration of a vaccine, it allows the body to produce antibodies without having to experience the disease. Immunized person, it remains unaware of the battle raging inside their body. All right, then you have natural immunity. The body experiences a full immune response with all the effects of the disease, and that's a natural immunity. So something like that, like chicken pox. So vaccines are going to produce immunity against the disease. The body develops antibodies in response to the vaccine. It produces an immune response to neutralize the invading disease. It develops antibodies in a controlled way. Okay. If the actual virus enters the body, the virus is going to be identified faster, or it's going to be identified, period, and the antibodies for that are going to be produced to kill it, right? So the immune system, it can become hypersensitive to one or more substances during abnormal reactions. An allergic reaction is going to be the reaction of the body's immune system that occurs when a person's been previously exposed or sensitized to a substance or an allergen. So in allergic reactions, allergic reactions versus anaphylaxis. So an allergic reaction is going to be mild and a localized reaction. The body limits the response to a specific area after being exposed to the foreign substance. Systemic reaction occurs throughout the body. Hypersensitivity occurs when a person reacts with exaggerated or inappropriate allergic symptoms after coming into contact with a substance perceived by the body to be harmful. Anaphylactic events shouldn't be mistaken for heart attacks, heat strokes, or other types of conditions. Diseases related to allergies, such as allergic rhinitis, asthma, and atopic dermatitis, they're going to increase the potential for anaphylactic reactions. So anaphylaxis is going to be a response mediated by IgE bodies. Anaphylactoid reaction is a response that does not involve IgE antibody mediation. And an anaphylactoid event may occur without the patient being previously exposed to the offending agent also. So pathophysiologic response, when an invading substance enters the body, mast cells recognize it's potentially harmful and begin to release chemical mediators, right? Like we saw in the picture. There are two types of chemical mediators. You have histamine, causes the blood vessels in the local area to dilate and capillaries to leak. You have leukotrienes are the most are more powerful than histamines, and they cause additional dilation and leaking. You got white blood cells that are called to the area to help engulf and destroy the enemy, right? And platelets they begin to collect and clump together or aggregate. In most cases, this overreaction to harmless invaders is restricted to the local area being invaded. Okay. So anaphylaxis. So as you can see there, the initial effects, release of the histamines, and then secondary effects may follow a few hours later. So the histamine release, it can cause immediate vasodilation, often presenting as flushed skin and hypotension. Um, it also can there's increased vascular permeability, resulting in angioedema. Edema can be present as urticaria or rashes, right? Airway constriction, and increased fluids in the airway. Smooth muscle contraction, especially in the respiratory and gastrointestinal systems. So this can result in laryngospasms, bronchospasms, and abdominal cramping. Now, it can also decrease contractility or the inotropic effect of the heart. When this effect is coupled with vasodilation, a person may experience a profound hypotension at that point, low blood pressure. So the later release of leukotriene compounds affects the histamines, and this is going to further compromise the respiratory status of that patient. It can cause coronary vasoconstriction, which worsens cardiac condition and myocardial irritability at that point. This is going to further contribute to the state of hypoperfusion. The remaining chemical mediators continue to worsen the situation. As a result, when the body undergoes an anaphylactic reaction, a person may not survive without immediate intervention. So you may need to get that EpiPen poked in them, not you, but them, right? So there's some clinical symptoms of anaphylaxis. You see there. So the symptoms can be slow or rapid. You may have less than 3 minutes to halt the process. So make your decisions quickly. React quickly. So the blood volume moving from the intravascular space to the extravascular space may cause shock. Uh, One bad thing is that the body will not tolerate an acute blood loss of greater than 20% of blood volume. So think about that when it's going into the extravascular spaces, getting away there because of that anaphylaxis. So on 1 second. All right, so this is highly challenging. Your patient assessment. So the simultaneous assessment, problem identification, and then intervention has got to be within seconds of arrival because it's crucial to make that fix. So a suspicion of anaphylaxis must be high if any of the pertinent symptoms are present there, right? So the response to the antigen may occur in a multi-step manner. You can see there. So the immediate acute response being followed later by a delayed response. The acute reactions have a rapid onset and typically result in the most life-threatening situation. Delayed reactions during this time, it could take hours or longer to manifest, and the response is not usually as exaggerated after that. So as always, make sure the scene is safe. Don't let your guard down. You don't want to end up in that bee's nest either. Whatever may have caused the anaphylactic reaction. Flying peanut butter. So some things you're listening for when you auscultate that patient is a harsh, high-pitched sound. So called stridor. You're looking for stridor. So that occurs when the swelling in the upper airway begins to close off the airway, and it can eventually lead to a total obstruction. So that's why you guys act quickly. Or if you ever seen Horton Hears a Who, you have to do this ASAP. Act swiftly, awesome pachyderm. My kid loves that movie. So you wanna possibly put that patient, or you want to position that alert patient in a tripod position, leaning forward. Feel free to initiate high flow oxygen therapy if needed. For unresponsive patients or altered patients who are in severe respiratory distress, you're going to assist those ventilations and attach that high O2 oxygen with that. You're going to palpate the presence of any quality radial pulse to quickly identify how the patient's circulatory system is responding to the reaction. Okay. So you're going to assess the patient, their rapid pulse rate. Are they cool, cyanotic, red, moist skin? Do they have delayed capillary refill? And that all may indicate hyperperfusion or hypoperfusion. You want to treat for those shock symptoms. So administer the oxygen, place the patient supine, and then also prevent the loss of body heat. So cover them up. That kid. All right. So sample history, you're going to check if your intervention's already been completed. Check and make sure how they're working. Check to see if the patient's experienced a severe allergic reaction in the past, and then be alert for any statements regarding previous exposure to common antigens from it. So you're going to perform a physical examination of the patient, auscultate for abnormal breath sounds, right? Uh, Carefully inspect the skin for a source of the reaction. See if you can find it. Uh, a rapidly spreading rash can be concerning because it may indicate a systemic reaction. Red hot skin is typical in the early stages and suggesting a systemic reaction. A So a systemic reaction, it also can alter mental status. So if you have the availability to do so, you can use a cardiac monitor for that, because some dysrhythmias can be associated with anaphylaxis. Monitoring a pulse ox for that low oxygen saturation will help assist you in identifying the degree of respiratory distress also. So factors such as decreased circulation exposure to carbon monoxide can alter pulse ox readings, so don't forget that. EtCO2 are going to be more reliable than the pulse ox in low perfusion states. Remember, gold standard, right? So in non-intubated patients, the waveform is going to be more important than the numeric value obtained during a capnography. The decision to administer O2 to a patient experiencing an allergic reaction, it should be based on a careful assessment of the patient's airway and breathing and not solely on pulse ox readings. So typically, your reassessment is going to be conducted en route to the receiving facility. Special attention needs to be given to airway compromise. Deterioration for this can be rapid and fatal, so you got to be quick. So one good way to do it is measure the patient's anxiety level and their mental levels. It's a pretty good way. Watch for signs of shock, and if you do see any, treat them immediately. So you want to identify, again, the severity of that reaction, right? So mild reactions may only require supportive care and monitoring. Anaphylaxis is going to require more aggressive treatment. So check the effects of epinephrine administrations if you've given that. Check the patient's condition if it's improved or if a second dose is going to be required. And then recheck those interventions as you go. Consult with your med control also. So for that, communication documentation. So when to contact the med control depends on your assessment findings, right? In some allergic reactions, you may need to use standing orders to administer the epinephrine, so make sure you know them. For less severe reactions, med control can advise you about the use of epinephrine if it's maybe necessary. Document all the signs and symptoms and explain why you chose to provide the care that you did in your documentation. And then make sure that you record the patient's response to that treatment as well. So it's essential to differentiate between anaphylaxis and other conditions, right? We beat that horse. So administering epinephrine. Early administration of epinephrine should be a priority for this. Use the IM route if the patient shows evidence of airway or respiratory compromise or hypotension. Administration in the thigh is preferred over the deltoid site for more rapid absorption. The subcutaneous administration of epinephrine is unpredictable and may have delayed effects in the presence of shock. So that IM route is going to be the way to go. That epinephrine, it can rapidly reverse the histamine related effects of anaphylaxis. So give it fast, give it early. Do I need to go over how to give epinephrine via EpiPen? Do I need to go over that?
Sure.
All right. I figured everybody might have learned. All right. So patients who receive epinephrine, they got to be monitored closely for adverse effects, right? Uh, Direct order from med control is required to use or to help a patient use the auto injector. Okay. In a life-threatening situation, don't delay the administration of epinephrine to expose the thigh. And an EpiPen can be administered directly through the clothing. Okay. So the injection time for this is 3 seconds. Uh, Take steps to ensure that the patient's leg does not move during the administration. You don't want to risk anything breaking off or anything happening like that. That wouldn't be good. After you're done, you need to properly dispose the injector after administration in a biohazard container. So make sure you throw it in your sharps container. If it's required that you need to give more than one injection, um, or if the patient displays decreased mental status or increased breathing difficulty or decreased blood pressure, you need to consult med control first, okay, before you give anything else. So some other allergy kits may contain oral or IM antihistamines, but they're comparatively slower than your EpiPens. So epinephrine and antihistamines are going to work synergistically, if you remember synergistic. Okay. Epinephrine may cause the patient's blood pressure to increase significantly, so make sure you're watching out for that. Some side effects of that epinephrine are right here. So if you're looking at all these side effects are definitely worth the trade-off of epinephrine if it's used in a life-threatening situation. I would say so. So one thing to remember though, if the patients who don't exhibit signs of respiratory compromise or hypotension, they don't meet the criteria for diagnosis of anaphylaxis. So in that instance, they should not be given the epinephrine. So you want to consider early transport if the patient needs resources beyond your capabilities. Even if you're able to stop the reaction and the patient begins to recover, it's recommended that the patient be observed in a medical facility, because as many as 20% of patients that have reoccurrence of symptoms within 8 hours, they can have a reoccurrence of their symptoms, even if they've been symptom free for that time in between. So they could be in the same reaction when 8 hours later. That means you'll be right back over there. And in most instances, that 8 hours later is what time? 2 o'clock in the morning. So insect stings. No bueno. Got ate up by ants. We years ago, I think my little boy was turning 3. I think he was turning 3. We got him a little jumpy castle in the backyard, and he'd been playing on it and everything, and at some point he came off the jumpy castle and he ran the back way around it, and there was a huge ant bed that was over there, and he stepped right in it, both feet. And those ants crawled all the way up his legs, ate him up. It took months for those bites to heal. That felt terrible. I was sitting there and I was trying to slap them things off of him and everything else, get all them damn ants off of him. I felt terrible. I went to war with every ant in that yard. I think I killed every living creature in that yard that had more than 4 legs. I was not happy about that. So a wheel is going to be what you see here. Right here. That is a wheel. It's just a raised, swollen, well-defined area of skin right there. Wheel. So applying ice sometimes make the wheels less irritating. You want to attempt to remove the stinger by scraping the skin with the edge of a sharp, stiff object like a credit card, preferably not a knife. You don't want to use tweezers or forceps, because what could happen then is that you may squeeze the stinger and inject more venom into the wound if you do that. That's why you want to scrape it off. So once the stinger is removed, you want to wash the area with soap and water or a mild antiseptic to try and get all that, get as much poison away from it if there's any outside or anything like that out of it. You want to remove any jewelry before the swelling starts, and then position the injection site slowly below the level of the heart, right? And apply ice or cold packs to that area. Slows it down. Got to be alert for airway swelling and other signs of anaphylaxis. You may want to place the patient in a supine position and give oxygen. And monitor the vital signs. So the best management of anaphylaxis and allergic reactions is to educate a patient about the prevention and self-preservation. Stay away from all that stuff. If you're allergic to it, stay away from it. All right. That went by really quickly. All right. So as I talked about before, close this out. We've got a lot to do this week, right? We hit on that a little bit. I'm looking it up right now. All right, so as I said before, you got a discussion that needs to be done. Only 4 people have done it. Let's get them knocked out. That's your module 3 discussion. Why is this being so slow? All right. You also have a chapter 21 and 22 test. They're going to be due, 21 and 22 are going to be due September 10th, which is Friday. Okay. You also, I see a few people haven't done chapters 23 or 24. There's only 5 attempts done on it. I don't have a close date on those, so get them done. Knock them out. I'm going to close those out because we've had a pretty good amount of time now. But I'm going to close those out probably Friday as well. All of them be closed out Friday. So if you haven't done it, knock them out. And then there is a module test, your module 3 test, which is 56 questions in 60 minutes. And that's going to be due by Sunday. If you want to study for it, I would highly advise that you look at your past test, your reviews, your feedbacks on your test. Also, most of it is based on patient assessment. So it'll be most of it is going to be patient assessment scenarios. So, you walk into a 56-year-old male, blah, blah, blah. Stuff like that. And it's going to be what a lot of your, if you remember the NREMT test, scenario-based. Yeah. Yep, the COVID and heart discussion. That's your chapter 3 or your module 3 discussion. If you've done it, you've done it. But I know there's like half the class hasn't done it. So I want to make sure he gets knocked out. But yep, that'll be done then. Do we have any questions about any of that so far? So a lot to do this week. I've got a lot to do too. So I got the due date on the COVID and the heart. I'm going to reset it. Because the cutoff date was, the cutoff date for it was actually today. But I'm going to reset it. For Friday. Okay. So you got the discussion. You got chapter 21, 22. And a couple of you have 23, 24, I think it was. Okay. To do. So let's make sure we finish it up. We got a lot. And then you also have the module test. The module test is the only one that is not due on Friday. It's due on Sunday. All the other stuff is due on Friday. So knock them out. If you have any questions or anything, please let me know. If you have any issues, let me know now. Or let me know as soon as possible so that we can get them sorted out, okay? That way we're not having to backtrack on a lot of stuff later on. All right? Awesome. Other than that, like I said, if your study material for the module test, when you're looking at it, most of it is scenario based and look at your past quizzes. That's going to help you out a ton. Okay? It is timed, so make sure you do it. Cole, remember the time change. Remember the time change, Cole. And let's get them knocked out. Okay? All right. I'm going to... Oh, are you... Oh, you're back now. Okay. Well, remember the time change again. Now you're back on this time. All right, I'm going to stop the recording. Oh, yeah. I don't think I have the numbers for those days, but I will give you the numbers for let me see here. I don't think I put codes on them, but today's code for the purposes of the video and for your time stuff is going to be 3421. 3421. All right, do I have any questions? Any questions before we go? 3421, that's right. Like I said, I'm glad everybody showed up tonight. That's awesome to see. Really appreciate that. Yesterday, or not yesterday, but Monday, I forgot that some people don't have Discord, so I apologize if you didn't get the message that we weren't going to be here. If it puts you out of your way or is an inconvenience in any way, I definitely apologize for that. Something else too. So last week when I had to, was it last Wednesday when I had to get off I was trying to rush through the class last Wednesday. Hold on.